Every leader has a strategy. Executing on that strategy is the challenge. If you want to learn how to effectively achieve what you've set out to accomplish, then this show is for you. Gain keen insights and listen in as leaders share their stories and challenges. SOAR Vision Group and the Baldrige Foundation welcome you to Leader Dialogue Radio.
Hi, everyone, and welcome to Leader Dialogue, brought to you by SOAR Vision Group and the Baldrige Foundation. I'm Duffy Dixon. Joining me is Jennifer Strahan. She's the Chief Operating Officer of SOAR Vision Group. Jennifer has partnered with more than 100 health systems and businesses across the U.S. She helps them transform their strategic and administrative operations. Next to her is Lisa Council, who is the Chief Commercial Officer for SOAR. She comes there after more than 2 decades of clinical, leadership, and clinical informatics experience. She spent 19 years at the McKesson Corporation. She leads where she was leading large teams in clinical consulting, EHR optimization, ROI teams, direct sales, and sales support. And most importantly, our guest this week is Nikki Buchanan. She is the General Manager of Population Insights and Care at Philips. Welcome, Nikki. We're happy to have you.
Hello. Thank you so much. It's a pleasure to be here.
We are excited you are here, and our first question is the easiest one. Tell us about who you are and what you do.
Sure. So again, Nikki Buchanan. I manage the Population Insights and Care group at Philips. We are an interesting software organization focused on healthcare and bringing the ecosystem, disparate systems within healthcare together. So within my division of Philips, because we are quite a large global company, I manage the population health management side, the telehealth and telemonitoring side, as well as the patient engagement side. And our goal, of course, as a business is to bring all of those wonderful parts of the healthcare ecosystem together and make a better experience for clinicians, physicians, and of course, patients.
So what is the partnership? What is the dynamic between you and SOAR Vision Group?
Great friends, great history with some of the leadership here, especially Lisa. We've known each other for years, and really interested in being able to share my experiences with Philips and healthcare, and seeing how the opportunity with SOAR can bring those kind of benefits together.
So one question that might be helpful for the audience is just to express a little bit around what is population health.
Sure. That's it's always number one, right? What does that mean? Because it means different in every business. Population health and the view of population health and managing patients has evolved, especially over the past 10 years, because of value-based care. Value-based care is a new industry thing within healthcare, and it's really driving towards having improved patient outcomes, reducing the cost of healthcare, and looking at more ways to prevent and provide wellness type support for patients so they're actually not in the hospital. We're looking at ways of managing their care in their normal setting, the home, in their daily life, looking for ways to bring them in earlier for physicals, improve their health, and prevent negative outcomes over time. Because we all know there's a chronic disease crisis within the U.S. healthcare system, and we're all looking for ways to reduce that over time.
So, Nikki, you were, again, I go way back with you on McKesson days, and then you worked for Wellcentive.
Correct.
Tell us a little bit about that journey where Philips acquired Wellcentive and how that transition has been from kind of exclusive pop health focus to a little bit more of a broader consumer perspective.
Yeah, absolutely. So Wellcentive was kind of first in class in the population health kind of market for almost 7 years. And we had the opportunity to interact and create great partnerships with organizations like Philips. Philips sought us specifically because of the fact that we had such a large customer base that was benefiting, truly benefiting from the value-based care contracts that they had entered into with the insurance companies in the U.S. So we were helping them monitor their quality, improve their quality, and ultimately achieve the outcomes they were looking for their patients, which was actually financially rewarding to them as well. So about 2015-16, we were available, on the market, and Philips came, and our leadership got together and met the Philips leadership team, and we realized, truly the Dutch mentality of caring for all and finding the best way and at the best price with the best outcomes was really a match to our vision to the market. And so, really when companies mix and companies get acquired, it's a it's a questionable time, right?
Sure.
As you go through that transition. But what I loved about our leadership team and what I loved about the Philips leadership team was we were all in it for the same reasons. And so when you find that blend of culture and that opportunity for cultures to come together and benefit globally, that's where we saw the chance as WellCentive to take all the good work we had done in the U.S. and North America and actually have the opportunity to transfer it into a global setting.
And I will attribute Nikki for her large customer base. She actually was the VP of customer service at the time, so grew that customer base, kept them very happy. So again, that was part of their desire when Philips actually acquired them.
Absolutely.
I'm curious, as you made your transition from kind of that domain around customer success into a general manager of 3 different segments inside of Philips. Do you find you're doing a lot of the same work? You're combining the activities?
It's actually probably 25% of my role, and this is, a lot by my choice, is still direct touch and engagement with the customer. I really feel like that's something that I'm just, a subject matter expert in, and I can always add value there. To your question, 75% of my time then is dedicated to the rest of managing the business, whether it be the sales, whether it be the marketing opportunities, or even just the general operational and process points. There's a lot of challenges, of course, in any business when you bring 3 parts of a business together. And mainly for us, we focused the first 6 to 12 months, and this is where I spent a lot of my time, was creating the new vision, the new definition of pop health within Philips. And that really meant for us, it was going to be meeting patients where they were in their most natural setting, which, as most of us know, that's home. So we looked at all the home assets we had, the telemonitoring business that we had, the telehealth business, the remote patient monitoring, the ability to survey patients on an iPad at home about how they're feeling today, to take their blood pressure, to get them on a scale and monitor their daily habits and daily routine. We figured, well, that is really meeting the patient where they are and getting those clinical inputs on a timely basis to our clinicians and to our customers so that they could take proactive care of these really at times fragile patients. So I spent a lot of time on that marketing message, on creating that story that we could take to HIMSS and other events throughout the year, such that people would see we weren't just a healthcare organization focused on in-hospital and all of the good that comes from that with Philips and lighting and its history. We had the opportunity to actually extend our services into the ambulatory and home environments.
And this is something where healthcare increasingly going to go to this telecare? And I guess my question is, will customers go for this, and why? Or why not?
Yes. So Lisa asked earlier, how did things change as we started to become more consumer focused? Consumerism is driving the changes in healthcare today. Healthcare, in my opinion, has taken way too long to catch up to where patients are and where patients expect service.
Wow, that sounds like what you always say, Jennifer. She's saying your words are coming out of her mouth.
I gave her a tip beforehand.
It's such an exciting time, I think, because maybe 10 years ago, the Amazons and the CVS changes of the world couldn't have been embraced, but there's absolutely a perception with consumers today that I should be able to get, let's take a typical situation. I should be able to get drugs delivered to my door, and I mean pharmaceutical drugs, recommended drugs, to my door, on a whim anytime, because that's where everything else in our world is going. I can get anything off of Amazon. Why can't my physician, who knows my personal history, knows my longitudinal record, right, has that data in front of them, why can't they prescribe something to me if I'm just having a quick FaceTime call and they know my entire history, they know my physical status? Why can't we just make the whole consumer-driven parts of the business that much easier and tangible? Whether it be you stop in at a Minute Clinic and just get validated by a nurse, or you get your flu shot and your whole family comes with you to get it done. I mean, there's so many opportunities and ways that we can bring the consumer side of health together, and it benefits the patient, it benefits the clinician, and it benefits healthcare overall, because we're not waiting for people to show up in the ER.
And people aren't waiting for hours in doctors' offices or ERs.
That's right.
So one of the things that I love that you mentioned, Nikki, is it's about putting care in the most natural setting.
Yes.
So when you think about one topic that I would love to explore a little bit, because we haven't talked about it on the show before, is relative to kind of the American expectations and some of the European and Scandinavian and Dutch expectations, which are very different, but yet at the same time, both bring exceptional value in different perspectives. Right. So what I love is that as a company, you guys can marry those things of what works, because the reality is we often think, well, we don't want to go to one extreme or the other, and it probably is somewhere in the middle that we need to meet. Sure. And so I love that you guys can actually explore that. Yeah. Can you talk a little bit about maybe some of the cultural pieces that have blended? And
this is probably one of the most exciting parts of my job, to be honest, to be able to be exposed to different cultures and the way they are treating and caring for patients, and to see how other cultures aren't necessarily as worried about liability. They're not as worried about privacy and confidentiality. Why? Because they've already dealt with those over the past several years, and they've gotten the patient buy-in. They've gotten the patient agreement that, yes, you can use my data to take proactive stance. That's still a huge barrier in the U.S. healthcare system. For sure. So to see other countries embrace it and say, no, I'm going to tell you, patient, how I'm going to use your data, and it's going to benefit you because I'm going to be more aware of your timely situation than I would be if I waited for you to show up in the hospital. So that's been refreshing. That's been exciting. I've also seen different uses of our technology in different ways in different markets. So our biggest first customer with telehealth almost 7 years ago was Australia. Australia and New Zealand adopted the practice of monitoring patients in the home as long as you met certain risk factors. And the way they presented it to the patient was, there is a score, there's an algorithm that is generated based on your behavior, based on what I see in your lab reports every year, and based on the chronic condition that you have. I can treat you, monitor you at home, and make you feel safe. I mean, think about it. There's people out in the bush in Australia. It takes 2.5 hours to get to a hospital. Right. They need some maintenance. That's right. They need some maintenance and follow-up at home. It's convenient for them. It's more likely that they will actually follow a regimen if they're monitoring and daily logging their systems or their their different circumstances in their life. So it was so cool to see that folks in Australia and New Zealand got through the interoperability barriers, they got through the privacy barriers, and they said, we're going to truly activate this. We're not looking for financial savings. We're looking for patient improvement, patient satisfaction, and patient outcomes. We want affinity of those patients to our health system, even if they're 3.5 hours away. So it depends on what model you want to talk about or how you want to deploy it. That's why we try to stay as neutral as we can in the technology, in removing the access or the barriers to the technology such that any model can fit and support the system. So we deploy change management services when needed. We look at the healthcare system to say, hey, how are you going to do this? And do you realize there's a cost investment here? But do you also realize if you're in a value-based care payment model, you may actually receive reimbursement? And I don't know if y'all have been following the legislation, but this year has been landmark for telehealth. Landmark. CMS patients can now be reimbursed for, not patients themselves, right, but the CMS provider, right, the deliveries can be reimbursed for a 40-minute, up to a 40-minute visit every month over the transaction or time of a year.
Which is huge.
It is huge.
That's been one of the biggest barriers.
Duffy, for you, there are physicians who still are not taking advantage, providers who have not leveraged this CMS law. I went into my doctor just recently and I was like, okay, are you doing telehealth? Can I FaceTime? No. And I said, why not? It's legally approved. Yes. You can get paid for it. So even in the Atlanta market, there's still laggards trying to catch up to the law.
So I go into my doctor, and this is good for people who are listening, and I say, are you complying? Is it, if it's a law or no?
Is it eligible?
Okay.
Yeah. And do you have the ability
to do CMS?
Just telehealth. Can you do remote visits? Can you do a FaceTime visit? Now again, there's certain rules that fall into that FaceTime visit.
Right. Yeah. But so the holdout was, wait a minute, we're not getting paid for our time.
Right. That's exactly right.
Bingo.
So what's interesting is you talked about Australian in the bush, and we kind of think like, oh, that's, there are images that come to mind from movies and everything else, but the reality is the majority of Americans are actually rural Americans. Like it's not everybody just as easy to come. So it's not unusual to see that. And then also, shameless plug, because obviously we have our event coming up in November with UAB and the Baldrige Foundation for rural health. And so it's an element where the benefit of that, especially with getting paid, is it adds to the viability of those organizations to remain independent, successful organizations and treat their patient populations.
You've hit on so many of the reasons why we're doing what we do. We really see the value, and that's actually in our roots, even as Wellcentive. We see the value of having that independent physician market available in any setting, rural or even, the urban settings, because if you have independent providers, you will always have objectivity in their diagnosis, in the way they treat. You can always get other opinions, right, from a large health system if you like, but we know with these independent providers, they've known a lot of these patients for a very, very long time. They've seen their entire family history, right, their children, their grandparents, etc. There's just huge opportunity to keep that affinity with their patients and where patients feel the most secure before having to result in care that may be specialized in a larger healthcare system.
Right, not to mention the fact, there's such a high percentage of non-compliance. So patients, again, who are not complying with either their medication regimen. So to Nikki's point, if meds come to their door, just like an Amazon package, then we've removed a barrier that you didn't have to go to the local Eckerd or CVS or whatever. Non-compliance, especially in the older population, is really a barrier to their health. So kudos to Philips to really taking down those barriers.
It's really been fun. I mean, just the opportunity to know in a day whether or not they're taking their meds, because it affects their blood pressure, it affects their weight, it affects their diet, it affects the way they feel. To be able to have intervention happen in 24 hours is a change in our healthcare system. It's a change in the way we're doing business with our patients, and we have just seen so many positive outcomes because of that.
You're saving lives and saving money, because if that patient, congestive heart failure, they start generating too much fluid in their body, they end up in the ER, there's greater expense, they could die. Again, there's so many components that you're touching.
Were preventable.
That's exactly right.
The other thing that I like about this is the perspective of from a facility, those small critical access hospitals, or again, some of those other areas. It gives them unique opportunities to partner with some of those rural or more urban hospitals that honestly don't necessarily need to treat the more acute and severe things, that those individuals could stay home in their own community with things like telehealth. So a colleague of mine who I've known for a few years is a CEO of a small critical access hospital, and they have a very unique partnership with a very well-known, a very successful organization at one of the other national known hospitals, where what this allows them to do is that what would be considered sort of an ICU for the critical access hospital, which is pretty minor for the large urban hospital, they keep those patients home, and they have telehealth with those specialists in the other larger hospitals. So there's also values, obviously there's a direct value to the patients, but also to providers and organizations that can allow those organizations to stay, again, independent.
Is it also a selling point to consumers that, during flu season, I mean,
it's a petri dish. Well, it's a petri dish everywhere you go.
Who wants to go to the doctor's office?
Right. Nobody.
Everyone needs a bubble at that point.
Right. There's recently on Family Feud, there was what are the number one places in a doctor's office where people leave germs? It was the most disgusting question.
Waiting
Magazines,
room.
the waiting room, the doorknob,
the remote control, like there's a television.
I mean,
crazy.
that's got to help. That's got to keep people healthier too, especially your critical populations, your elderly, your small children. I mean, stay away from the germ zone, man.
I take my son, so my son's 3.5, right? And I'll take him in the pediatrician, they have a sick side and a well side. And you appreciate when you're well, but when you're sick, like I walk in and I'll literally hold him in the middle of the room and I'm like, don't touch any chairs. Don't sit. Like,
and
just
they'll
don't
have like a
touch
little
anything.
game on the table in the sick area. Like you can't touch
no.
that. It's like, why can't I touch?
Well, and they've gone to, at my doctor's office, there are masks. And they say, if you are sick, put that mask on, which is huge. And I thought, that's genius. But again, it's got to be a selling point that it keeps people, because a lot of people don't go to the doctor because of things like that.
For sure.
Absolutely.
For sure.
Well, random note, but speaking of masks, I was walking, because, we spend a lot of times not only in hospitals, but in airports. I was walking through the airport and I saw someone with a mask on, and I was thinking like, I hate that, but I am so glad you're wearing a mask.
I know.
Thank you. Yes. That was my response. And I'm thinking we need to do that more, because it's not flu season, but it's such an important endeavor. But it even goes back to the culture of what we talk about from, again, more of that Dutch culture. There is a responsibility to think broader than us, right? Ourselves, but think about society.
Yeah, and there's varying opinions on why that is so ingrained. In certain countries, the government is responsible for healthcare, right? Overall, completely 100%. So maybe that's part of the culture that they've grown up in. So they've always looked for alternatives. But I also think an interesting thing that I see in other countries as well, and you guys both hit on it, there is a community aspect to health and healthcare. And the more and more we can get health systems, health providers working and interacting with the community health networks, right? The social services, the drivers, the Uber drivers, right? I mean, Uber and Lyft showed up at HIMSS this year with huge booths, right? They are a part of healthcare now. Yep. So when you start to think of the whole social determinants, what's going on in a community, how can a community jump in and be a part of the system? Even just driving somebody to their doctor's appointment because it's the same person that takes them to their church event on Sundays. I mean, we need to tap into these networks, right? Because if you can do that, you again bring healthcare closer to home. And home may not be the home or the apartment someone lives in. It may be in their community environment, their church, or their, the place that they do their social activities, walking in the park. I mean, imagine if there was the mammogram on wheels type situation. Imagine if there were flu shots available in your local park or at the local Publix down the street. I mean, it makes us question our current setup in every way when you start to think about, how am I going to reach people? Right. How am I going to prevent these things? How am I going to improve wellness over time? And how am I going to sustain people in the most natural setting? So huge opportunity.
And you have actually been able to take this message globally.
Yes.
You were a presenter at the World Health Organization,
yes.
which is a very big deal for our audience.
Yep.
So tell us a little bit about, again, how you you came to that and what the outcome was.
So, first of all, were you nervous?
Oh, I was.
That's a big deal.
I was terrified, but I was equally excited. So, the WHO is like the mecca of healthcare and public health, right? So that's a lot of my background. So I was just so excited at the opportunity to be able to do it. But the thing that was the most rewarding was that globally, healthcare is just, it's a priority for all of us. And so when you get with many nations, we had 12 different nations involved in the study that we were doing and providing kind of best practices across how do you get vaccines to patients in their, again, most common setting. When everyone is involved and coming from that point of thinking, you can remove so many barriers. And so that was the most exciting and rewarding thing for me, was to deliver a truly ROI driven, let's write requirements together and agree upon those for 12 different countries. Let's figure out what we all have in common, and then let's create a system, a technology to support the things that we all have in common. Because that, again, is one of the biggest barriers in U.S. healthcare. There are very few standards, but yet we're heavily regulated by the FDA with what we can do. We're heavily monitored. So we've almost taken the extreme effect of, preventing suing and financial disaster, right? Litigation. And instead, if you look at it more from what's a standard that we all have in common, and write requirements such that all these things can be redelivered and repurposed in multiple places, that's when you start to hit to ROI. And that's where you start to work with technology companies like us and others out there who say, I can create one product, which reduces cost by creating one product, and I can deliver it in multiple ways, right, or in multiple locations. It's when you have to nuance and change the standard for every country, that's when product prices start to soar, because you're meeting regulatory demands in each of the countries. So, we look globally at Philips, we look for ICHOM standards, like we look for things that are globally driven requirements that have been agreed upon at a standards level. And when we can find those, and then we can take them to a health system and say, we followed the rules from this group. Do you agree that those rules are the most important? It's like ICD-10, right, in the U.S. If you can share with them, we've looked at best practices and these are validated, that changes the game in the conversation. Because now they suddenly say, okay, I was thinking about doing a telehealth pilot, but you're following a standard from another country, and that standard tells me you've already piloted this. Maybe we'll do a pilot, but maybe we'll just do a shorter one, or maybe we'll go ahead and reach out to more people that we weren't originally going to do, because we know it's based on standards or evidence-based guidelines.
And pilots usually consist of lower dollars. They don't want to pay as much for a test, a trial, we providers, from a technology, we don't like those necessarily. So again, if there's already been some proof in your business practices, then it again makes for an easier contracting, for a longer term of engagement, lots of really good things.
And it accelerates the ROI.
For sure.
Right? So, we've got some wonderful customers that are all about doing the pilot thing, but what I love about these pilots is they've also said, you prove to us either financial or clinical outcomes within 90 to 120 days, or even just reductions in things, right? Costs, behaviors, visits, whatever it may be. If you can prove those in 90 to 120 days, we will keep on going. So it's like opening the floodgates. And that, we need to be more bold in doing that in healthcare. That's because you hate to think of an end to a pilot and then waiting again to start it up. Let's just agree that if we're successful and we prove our side of it, and so that we have to get into risk contracts a lot of times with pilot type customers. If we prove it, you'll let us just keep going.
That's
because you've done so much to get the clinical workflow change and where it is. Let's keep moving if everyone in some way benefits from this.
Perfect.
So, Nikki, based on your experience, you've been working with a lot of these organizations. You've seen a lot of people probably approaching things in different ways because of, as you mentioned, the lack of a standard that is not necessarily known. What are some of the things that you have seen that have been very successful for either organizations that when they've brought population health to their community, right, and their business model? What are some of those wins that you could share?
And actually, Lisa touched on one of them. I don't know if she had been researching us to know, but we ask anyone who's reluctant or scared to start to focus on a single chronic disease or a single condition that we know cannot be treated on a daily basis in a hospital, but can be treated over time. So CHF patients, chronic heart failure, COPD patients, diabetics, right? There's varying levels and stages of diabetes. These are all simple, protocol-driven, evidence-based, guideline-driven care guidelines. Let's follow those and let's think of them outside of the hospital setting. And if you just start with one of those, you easily adapt over time to multiple conditions. We also have customers who have said, you know what, we just want to get our wait times down in the ER. You hit on that earlier. Well, okay, what if we set up a remote patient monitoring type opportunity for patients who are waiting to come to the hospital or are waiting or wanting to go through the ED? What if we had a way to talk to them and triage them before they ever left their house? Right? There's just many different ways we can frame it, either starting in the home or going to the home post-hospital visit. But again, start small. Start with a measurement of patients that you want to see some outcomes with, maybe tie it to a value-based care reimbursement program, and then monitor it in 30, 60, 90-day increments. That's usually the health plan guideline anyways when you discharge a patient.
Right.
30, 45, 60, and 90-day readmits, right? So follow the protocols of the health system. Start it small and then grow it over time.
So tell me what this means for the customer. If I'm at home and I am, I've just been diagnosed with diabetes. Obviously, you want to know my levels of things, right?
Yes.
Blood levels, everything else. What would be my part in this?
Yes.
So obviously, I can FaceTime you, and you can tell me what I need to do. Do I get on my computer and input information? Do you call me? I mean, tell me.
Yeah. All of the above,
okay,
or none of the above.
Okay.
It truly, this is where when you're thinking of deploying these types of services, you really have to understand your patient population already. So we have devices, iPads, that can go home with a patient at the time of discharge, and they can simply input the values on the iPad. That's great for my 20-something, right. Niece or nephew. That's not so great for my 70-year-old grandfather.
Right.
So if you want to reach all of these different types of people in the population, then you have to almost deploy separate services or look at the services differently. For my 75-year-old grandfather, it may be a touch point every day and a phone call that is 3 minutes long. Tell me your BP, tell me your weight, and tell me how you're generally feeling today. Right. Or do the smiley face reaction, right? Are you feeling great? Is the mood good? Or are you sad or depressed today? Give me those indicators. Or to your earlier question, could it be on a computer? Absolutely, as long as that mechanism is tied to a portal within the health system. Okay. So we can deploy any of those variables. It's just a matter of figuring out what's right for the condition or the person you're trying to manage.
And I'm thinking with every year, this gets a little easier because to be honest with you, grandparents FaceTime their grandkids.
It's
so if you
so
can do it
much
for
easier.
them,
That's right.
My mother is the last holdout, but that's because I don't have grandchildren. I don't have grandchildren for her. I think she would be totally savvy if she had something that she really wanted to see besides me. Yeah, but it's true. I mean, that is no longer a foreign concept.
That's
right.
That's right. So imagine 10 years from now,
Yeah.
you know, we'll be laughing about the fact that we thought this was such a big barrier in healthcare, or that we needed to do so many legislative things to move. We'll be laughing. We'll be saying, why didn't we do this sooner? Well, we're trying to catch up with the technology in healthcare. That's always been the problem.
But I do think privacy, again, I think privacy is a big barrier in the U.S.
Huge barrier.
Again, transferring electronic data, is that really safe?
Yep.
Is someone going to gain access?
Yep.
So it sounds as though other countries may be a little further along than we are in the U.S., which I'm, very disappointed about that.
Yep. To your point, there's personal health records in other countries
For
today
sure.
that match and then work into an EMR.
Right.
So I know we are coming up on our time, which has been great discussion. So just a few things that popped into my mind to kind of wrap up and think about the key topics, and I would love for us to dive into a little bit more on a few of these. One is, obviously this is a new way of thinking, although it's questionable if it really should be new per se, because we've been doing this. But the biggest transition is really with thinking about preventive things that, again, keep the patients in their natural care setting, right, in their home, because they don't want to come in, even though, yes, you always have a few for the most part. They don't want to be there at the hospital, right, or at the doctor's office. They want to be home with family in their space. The second thing is really around cultural transformation and the way of thinking from a broad community as well as from an individual provider standpoint and across the board. And, of course, the barriers that may help and or hinder that cultural transformation, the structural pieces like the payment models that support the operating system of the actual telehealth structure. But the other thing that really resonated with me was when you were talking about piloting and where to start. It's you think big, but you really start small, right? And so it goes back to the old saying of how do you eat an elephant one bite at a time. And as simple as it is, I feel like my grandparents used to say this all the time, and you kind of laugh, but it's so true in everything we do. But the one thing I would say to just bring this back to the Baldrige hierarchy of needs is if we remember what this is going into is really around that customer value. At the end of the day, when we look at that hierarchy, are we creating a system that brings value to our customers and that our teams, our employees and colleagues can actually deliver on by setting that up in a way that constantly brings value? And then it naturally drives the things we've talked about with ROI and outcomes and other different settings.
We're going to meet again with you next week, and we are going to dive into those very concepts. But for now, we want to thank everyone for joining us on this Leader Dialogue, brought to you by SOAR Vision Group and the Baldrige Foundation. Remember, you can listen to a new live show every Friday at 1 o'clock Eastern Time. Visit businessradiox.com, click on the Gwinnett Studio, and select our show Leader Dialogue. You can also just go to leaderdialogue.com/podcast. On behalf of Jennifer, Lisa, and our producers, Trey and Mike, I'm Duffy Dixon. Join us next time on Leader Dialogue here on Business Radio X.